for showing up here, and thanks for showing up online. Had a couple requests to redo the talk on the Gonstead system and what's the difference and where did it all start, all those good things. So we're going to go over that, and I just had a conversation with the head gal at the school who's in charge of the intern program, and I'll be a little bit fiery tonight because so when I say the Gonstead Technique, everybody assumes that, you know, chiropractic is chiropractic unless you know better, and that all chiropractors are the same, and they all like dentists or something like that, where they all drill teeth and there's over 200 named techniques now at this point, and more coming about every year. So Gonstead is one of those 200 techniques, and it started by Clarence Gonstead back in 1924. He graduated from Palmer. So Palmer was the first and only chiropractic clinic at that time, I believe. And Dee Palmer, the guy who discovered chiropractic, he and his guys were teaching at the school at that time, and his son, BJ, was doing research and starting to develop some other techniques. So at the time when Dr. Gonstead went through, now a little bit background on Dr. Gonstead, as a child he had juvenile rheumatoid arthritis, and he went to a chiropractor and got adjusted, and it actually cured him of his rheumatoid arthritis. So that inspired him to become a chiropractor, but later in life, through his work, he went to school and he became a structural engineer, a mechanical engineer, and he had that structural mind. So he did go to chiropractic school at Palmer, where he was taught the prevailing technique of the time was full spine, okay, from top all the way down, toggle, which means they would contact the bone specifically, and when we say specifically, like there's two segments of the spine, okay? So this little nose-looking piece is the spinous process. They would either contact that, or if there was a lot of rotation in that misalignment, they would contact one of these little processes here to take that rotation out so that they could get 3 dimensions of that misalignment, that subluxation out in one adjustment. So that's a specific adjustment, okay? Being directly on that subluxation, and they had a whole list of analysis that they would go through to find that subluxation, including the tools that we're going to talk about in the Gonstead system, and that's where he learned that from, okay? That's why we still use those techniques of analysis today. And then the specific adjusting, he was taught full spine toggle, and he was the first guy to actually apply the level base theory of engineering to the spine, okay? And they did full spine films. Dr. Gonstead, taught full spine films because then you can see if the base is level, how is it going to affect, or if it isn't level, how is it going to affect everything above it. And a lot of times they were doing majors and minors, so they would find the major subluxation and just adjust that, and then monitor the minors to see if they would correct themselves. And so if the major was, let's say, an L5, which is at the base of the spine, and it was crooked and it was throwing everything off, then up here at the neck, it had to, kink to get your head back to center, that would be considered a minor. And 80% of the time, if they fixed the major, that minor would correct itself, okay, unless it had been there long enough to heal in that position, and then they would have to address that specifically. But they did everything, all the segments specifically, they just did toggle. So what that is they would contact the bone, they'd figure out which direction it had to go, and then, our knee-chest table where you're on your knees and then you put your chest and your face, and your spine just kind of hangs loose like that. they would get on that segment and they would shove it and then immediately release so that the body would toggle or recoil. It's called toggle recoil. So the body would recoil, and that recoil, not the thrust, but the recoil would suck that bone back to where it was supposed to be. It was more of a way of getting the body to adjust itself. Okay, so they would provide that force, and then they would get off that bone as quickly as possible. And what Dr. Gonstead did is he started doing research after he got out of school with his patients, and he found, we can get better structural change if we focus on that disc. So the big difference between Gonstead and every other technique is that we focus on the disc. So if somebody has a herniated disc or a slip disc, you guys have all heard of those bulging discs, that's what we're looking at. And in a subluxation, when there's a misalignment of the spine, it's the disc that actually heals goofy, or the nucleus moves to a different position and holds that malposition. Okay, if the disc wasn't malformed in an injury, there wouldn't be malposition. So he determined that adjusting with a set and hold rather than a recoil affected that disc optimally. So we went away from the recoil, the toggle. Okay, still specific, full spine adjusting. He also noted that in an area with a curve, like the cervicals, it benefits to adjust that bone in an upright position. So with that curve in the neck, being able to adjust it seated, and again, that you'll see most chiropractors don't do a specific technique. They do what they call diversified, which really isn't even chiropractic. It's a kind of a hodgepodge of osteopathy, which, if you remember one of the previous talks, Andrew Pierce Still was the guy who developed osteopathy. He came along about the same time as D.D. Palmer, and they were looking at general mobilization or manipulation, general, in an area of the spine to increase blood flow, because it does that. If you blast an area of the spine, it'll increase the blood flow because there's a sympathetic response of all those nerves in that area that open up all the blood vessels and increase the blood flow. So they were using what he called manipulative medicine. So if I have asthma, my lungs aren't working at 100%, if they go into those nerves, the bones that protect the nerves of the lungs, and they do a big general push in that area and fire off a bunch of receptors, what they would find is that those lungs would respond, again, the sympathetic response. They'd open up along with the blood vessels, everything would open up and it would actually improve, okay? So the difference between manipulative medicine and chiropractic, an actual adjustment, is that the manipulative medicine is based on stimulation, okay? And stimulating a nerve to mimic its proper response. Whereas a true chiropractic adjustment would find where that specific interference is and remove that so that the nerve functions normally, rather than stimulating it to mimic a proper function. Does that make sense? So that's the difference between a specific adjustment and a general manipulation. So well over 90, probably 95% of the chiropractors out there today don't do a specific technique. They do what they call diversified, which again, it's a hodgepodge of physical therapy, osteopathy, mainly those two. There's not a lot of chiropractic actually mixed into it. So somebody asked me today, the schools don't teach, like Gonstead, they don't teach any specific techniques. You might have like an elective, like we had a Gonstead elective. The guy teaching it didn't do Gonstead. He didn't know anything about an actual Gonstead adjustment. He never used any of the tools that a doctor would analyze with. It was just, credits that they could say, oh, you took this Gonstead elective or whatever, so that somebody could get on a So most of the time, if you're looking for a chiropractor, you can call and ask what technique the doctor does. If the front desk girl doesn't know or guy doesn't know what technique they do specifically, they don't do a specific technique. Because people that do Gonstead, people that do upper cervical techniques, there's some really good specific upper cervical techniques. People that do Thompson or any of the named specific techniques that are full spine or even just upper cervical, they know. The people that work there know this is why we're different. Okay, so if you're looking for a chiropractor, like last time there was somebody down in Arizona that we were trying to get them lined up with a Gonstead doc, and it's just heck to find a Gonstead doc in their area, and they started calling around asking, what technique does your doc? Oh, I don't know. If you don't know, they probably don't do a specific technique. They just do a general manipulation. So what that looks like, we call it the Flying Seven, which we don't do here. But they'll bring a person in. They don't really do an analysis. They put them on their side, grab their butt, grab their shoulder, wrench them out, manipulate every joint in the spine that way, flip them over on the other side, grab their shoulder, grab their butt, wrench them out that way. And that's just general manipulation, mobilization, or that rotation. Okay, it just causes a lot of damage to the disc, so that's why we don't do rotation, in our adjustments, or minimal rotation, and we don't use long levers like a shoulder and a hip and a long lever manipulation. So again, that's the difference. Then they'll usually put you on your face, do 3 cracks up the middle, put you on your back, spin your head left, spin it right, and it's basically taking those joints to their end feel and then pushing them further, okay? Whereas Gonstead adjustments are all done from a neutral position, okay? So if you're sitting in the chair and I get under that bone, you're slightly tilted, but you're looking forward, and I don't crank the head one way or the other. I adjust that thing back up on its disc level, and you're still looking straight ahead, or when we do something in the thoracics and you're laying down and we get on that bone, specifically with 2 thumbs or with that bone in my hand, we just move that one bone in the direction that it needs to go. That's the difference between a specific adjustment and then just getting my whole arm in there and blasting every joint in that place. So that's the background on Dr. Gonstead. They didn't have, they had osteopathy back in those days because that was just starting out, and people knew the difference. It's like these guys do something, related to blood flow, whereas these guys are talking more about the nervous system, and that's why we would be specific, because just doing a blast general, manipulation doesn't affect the nerve as well as it does, increase blood flow. So we're trying to affect that disc, which then the thickness of that disc, remember, is what opens up the hole for the nerve. Okay, so if we can keep that disc level and keep it healthy, that keeps enough space for the nervous system. So Gonstead started his practice in a little town, Mount Cora, Wisconsin, and he built it up to the point where people were coming from all over the world. He actually had back here an airstrip put in. So this is the clinic. It was designed by Frank Lloyd Wright, and you can still go visit it today. It's still running. And then down here, that was a hotel that he added to the property so that people coming in from out of state, out of town, out of the country could stay there and get adjusted for a week or 2 weeks or whatever, and then fly back home. So it was an insanely huge practice for its time, the biggest, at that point, and probably still one of the top 3 biggest chiropractic offices ever. So his fame spread worldwide pretty quick. So he was just looking at subluxation. He didn't do massage. He didn't have physical therapists on staff. He was just finding subluxations and correcting them. That was his bread and butter. So that's what we do. And the reason we do that is because, the the nervous system controls everything. So you can have that subluxation, not necessarily have pain, but it's going to affect the function. So when we do our analysis, we look at some functional tests. And again, that's probably a big difference between us and what most chiropractors do. Is we have a seven-step analysis process that we do to help us find specifically what we need to adjust to get that person back to normal function. So we do instrumentation, and we have a couple different instruments that we use. We do some thermography, just a thermograph roll on the spine, and sometimes an EMG, depending on what the person comes in with and what we need to look at. And then we also have our handheld unit, which is a version of thermography, but basically that nervoscope is a neurocalorimeter. It looks at the calorific nerve function at that level. It's kind of like a modified version of a resistance meter, because the nervous system is electrical. And when you have resistance on an electrical wire, it's going to produce heat. Same thing happens in the body, and that's what that neurocalorimeter or that nervoscope is. We also do static and motion palpation. We also just do visualization. Like we'll look at a person's posture, like this is a postural analysis. Okay, I can see that guy's got curve in his spine. I'm usually watching people as they walk in to look at the hips and see how they go from seated, standing to seated, and seated to standing. When they lay down, we'll look at the posture, but also the leg length. So we do some leg checks. We do motion palpation, again, which is just palpating how that bone is moving. And then we do x-ray as well. So our analysis, is far beyond what most chiropractors do. You go to the chiropractor down the street, you'll walk in, they'll ask, where does it hurt? And then they'll put you down on a bench and give you the flying seven and send you on. They'll probably hook you up to a couple therapies or put you on a heat pack or an ice pack or send you to their massage therapist or whatever. But they're not looking for that subluxation or that specific. They're doing general manipulation, okay? There are good specific techniques. So, some people just don't do well with my technique, the Gonstead technique. So I know all the other specific docs in the area, and we'll usually find somebody specific at least that we can refer them to if they're not going to do well with the Gonstead system. So most chiropractors, when I talk to patients coming in who come from another chiropractor who didn't get a result, I'll always ask them, did they do an x-ray? No, they never did an x-ray. Again, when I described the flying seven, 90+% of them just came in, got the flying seven, and got sent out the door, okay? So, when we look at the nervous system, all right, some of the tests that we're doing look specifically at structure, like the postural things, but some of the tests that we're doing look at, like symptomatology, just mainly looks at the pain-sensitive nerves. When I poke somebody and they say, yeah, that's tender, that's symptomatology is one of those techniques of analysis that we use, but it doesn't have to be, symptomatology is kind of misunderstood. People think they're complaining when they come in and say, this hurt or that hurt. But that's just one portion of the nervous system that we look at. When somebody comes in, the nerves that control the muscles and they have spasm or tightness or, knots, that's another bit of information that we're looking at a different part of that same nerve usually. But the nerves that control the organs, that's the one that gets most commonly misunderstood. Because the autonomic parts of the nervous system, the sympathetic and the parasympathetic, which are like the gas and the brake for all the organs. So if you take any organ or any gland, those organs like your heart, for example, it's supposed to be beating at, whatever your normal heart rate is. And if all of a sudden it's beating faster, well, there's a couple things that could be going on, okay? It could be a subluxation that's putting pressure on one of those sympathetic nerves, which would actually speed the heart up initially, okay, when it's acute. But later, as those subluxations go into chronic mode and those nerves start to degenerate, it'll actually slow the heart down, okay? So initial subluxations, when they're acute, they irritate that nerve and it'll stimulate it, overstimulate it. But there's also a possibility, if that heart rate is too high, that the parasympathetic part of the nervous system, which is kind of like the brake, it regulates that so that it doesn't run out of control. It's supposed to kind of put the, tone in the body is like we got the brake and the gas on partially at all times, okay? You grab somebody's arm, they got a tone there. It's not just dead, loose, paralysis. There's a tone there. You can kind of think of all the different organs and the glands have a tone, okay? And there's a balance between those two parts of the nervous system, the brake and the gas, or the sympathetic and parasympathetic. So if they're not getting enough brake, all right, now it appears like there's too much gas and it's just running too fast. But again, that's one tool that we use, and that by itself gives us some information, but it doesn't tell us everything. It tells us a lot, but it doesn't tell us everything because we don't know now, is it a sympathetic or parasympathetic problem, okay? If they've got a visceral problem, like your stomach is, acid, too acidy, or your respiration is too frequent, or, your heart rate's too high, blood pressure's too high, bowel movement's too high, all those things can be on one end or the other, okay? So that's why we ask about those things, and we don't consider it complaining when somebody comes in and said, yeah, this hurt or that hurt, or my heart rate was pounding on my chest last night. Those things are part of our analysis, okay? So don't feel bad if you come in and you're talking about bodily functions. Yeah, some people think that's gross, but we need to know that information if we're going to actually find the right bone and get that thing adjusted the way it's supposed to be, get you back to the normal function. So we look at those three parts of the nervous system, or parts of the nerve, and we'll use, instrumentation. Sometimes the thermography will check that sympathetic portion of the nervous system. The EMG, when and if we have to use that, that's looking at the motor nerve that controls those muscles. And then that handheld unit actually looks at, again, the balance between sympathetic and parasympathetic. And of course, x-rays, most chiropractors, if they take an x-ray, they're going to do a sectional, okay? Meaning, you come in with neck pain, they're going to take a picture of your neck. Come in with low back pain, they're going to take a picture of your low back. In the Gonstead system, we do a full spine, and again, the reason is Dr. Gonstead was a mechanical engineer, and he looked at the mechanics of the spine under gravity. We gotta do it under gravity. It makes no sense to do an x-ray laying down, but they do MRIs of the spine laying down all the time, okay? So it takes gravity off the situation. When you're looking at a guy like this, who's got, a subluxation down here, and it sends things off center, and then up here, we can see it tries to compensate back and come back to the plumb line, but it doesn't get there. This guy's probably going to have pain at some of those buckling points, all right? He might not even have pain down here initially. It might be up where there's the biggest curves and the biggest, buckling point under gravity. And if this guy comes in with mid-back pain and I only shoot that picture, between here and here, and all I see is, oh, he's got a curve there, he's got scoliosis. Okay, what are your treatment options? I have no idea. You just pound on that until it goes straight? Not likely. So in the Gonstead system, we're always looking for the cause and effect. So if this actually is the first thing that throws him off center there, then this curve, which actually tries to get him back, when you look at it, tries to get him back to center, that's a minor, or that's a compensation. So we don't adjust compensations. Usually, like I said, 80% of the time, if you correct that major that caused that compensation, the body will correct itself. So if we take the pressure off down here, 8 times out of 10, it'll correct that. It'll come back into center, and it'll straighten all this out by itself, and I never have to touch it, okay? So that's one good reason why we x-ray, and we also do a full spine, because just because you have pain here doesn't mean that's where the cause of it started, okay? Same thing up in the neck. Just because we have pain in the neck, that atlas, that top bone in your neck, 80% of the time has to compensate for something going on down lower. So that's never going to be pleasant if your atlas has to compensate for a short leg or something like that. It's always going to be kind of, cockeyed, for lack of a better word, and it's going to be kind of irritated a lot of times, and the motion isn't going to be right. You're not going to be able to look equally over both shoulders. So that's why I think it's important to look, again, and do that analysis, what we would call a majors analysis, and look for those majors and correct those so that those minors see if it's going to correct itself, because a good majority of the time it's going to, okay? But again, that's something that is specific right now to the Gonstead system. So if you see full spine x-rays, you're probably looking at a Gonstead doctor. I guess there are some activator doctors who do specific activator protocol. Most chiropractors, again, the 90+% that do Fine 7, they have an activator in the drawer. They've never been trained on how to use it. They'll put it on people and they'll click it when they're afraid to adjust somebody. Like if somebody's got osteoporosis or something like that and they think, oh my gosh, I'm gonna break this person's bones or something, they'll break out that activator and click on the person. Again, most of them have never been trained in activator protocol, so they don't really know what they're doing there. There's one guy in town actually who was trained in the specific activator protocol, and I will send people over to him because I know he's gonna get the change, because he and I have sent each other patients and before and after x-rays, and I know what he's doing, and he's doing good specific work. It might take him a little longer to get it than how I would do it, but he's going to get that change because he's specifically on the right bone and he does that analysis, okay? So, the nervous scope, again, that's what I was telling you about. Neurocalorimeter is the fancy name for it, but again, it's basically a modified version of a resistance meter that works in the body, because in the body there's an electrical system, and the same rules apply to your house as to your body. When you got resistance on a wire or it's resistance on a nerve, you can pick it up with a resistance meter. It's usually looking for a difference in frequency there or heat, and that's pretty much the same thing in the body, okay? So right now, two techniques use this instrumentation. Okay, there's an upper cervical technique that actually uses that as their analysis for not what to adjust or where to adjust, but when to adjust. So they'll run that. Usually it can hook up to a graph, and they'll look at that person's pattern. They'll use pattern work. They'll use a break analysis, which means, like in Gonstead, we'll do a break analysis where I'll run that meter and I'll find where each individual nerve pressure is, and we call that a break, okay? So we'll mark those, and then we'll look at the x-ray and our other tools to decide what's the major here, what are minors, what are we gonna work on. But in those upper cervical techniques, the ones that are specific will use this and look at that person's pattern to see if they're adjusting, if they're adapting. If they're not, if things are staying the same and they're getting worse with time, they'll be able to see that every time they do that pattern. They'll look at it and say, okay, he's in that pattern he was in, or she was in when they came in and they were in rough shape, okay, and they weren't functioning right, and then we adjusted them, we got them out of that pattern so their body was adapting, and all of a sudden things start working right, things start healing, and now, as long as they're not going back to that pattern, we're going to leave it alone, okay? That's kind of an upper cervical analysis, is if they're adjusting or adapting, that's as much as we can do for that person's body, upper cervically speaking, okay? So we're going to do that analysis, and as long as they're adapting, we're going to leave it alone. Whereas in a structural technique, we'll look at the structure, but also the nervous system, and say, okay, if we leave this person alone today, they might not have symptoms yet, but their leg length is off, that hip is off, we're going to have to adjust that eventually, or they're going to have this issue. It's going to wear out that L5 disc. So we don't just use that again. It's a great tool, and I wish more chiropractors used it because it gives you a ton of information, no matter how you use it, whether you do break analysis or pattern analysis. But again, it doesn't tell us everything. That's why we use 7 different tools and come together with all of those to figure out what we're going to adjust. We don't do the flying 7, okay? So here's some examples of the flying 7. Again, put you on your side, crank you all the way over, shoulder, grab them butt, jump on them usually. Usually they'll use their chest on the person's hip or leg. And here again, that's what they call a rotary brake. So they take the person's head, they spin it as far as it'll go one direction, and then go further, okay? Whereas in the Gonstead system, there shouldn't be any rotation in a good, clean Gonstead adjustment, okay? Sometimes we get sloppy, but most of the time, it's gonna be from a neutral position, right? I'm sitting here in a neutral position, and I can just get on a specific part of that bone and get that bone to go the direction that I want to, okay? I can either do a push or I can do a pull. So let's just focus on rotation here, because sometimes I know people get kind of confused about this, and they'll come in and they'll say, okay, why didn't you do the other side? Well, because we don't do general manipulation here. I'm looking at how that bone is positioned on that x-ray, and if it's rotated over like this, if I do a move to move it back like that, why would I go over on the other side and undo what I just did, okay? So we're gonna say this little nose has rotated over to the right here, okay? When we were looking at it from your perspective, it's your right. And it's the patient's right as well. So a push move would be, I'm gonna get under this little piece of bone and I'm gonna push it back to neutral. A pull move would be, I'm gonna get on this piece of bone and I'm gonna pull it this direction, all right? So sometimes a person doesn't respond great to a push move or a pull move. So I will go over on the other side and try the opposite move. It's not the same thing as cranking their head one way and then cranking it all the way the other way. I'm still doing that specific adjustment. I'm just moving that one bone. I'm not doing a manipulation of all the joints here. I'm just trying either a push move on that part of the bone or a pull move on that part of the bone, okay? So sometimes you might come in, get an adjustment, and notice, oh, he moved over, he was on the other side. He contacted that bone on the other side, or he used his other hand. It's just because of how that bone was positioned, or what the scope told me, or how your head was positioned, made me think that, okay, maybe I should try a push move, or I should try that pull move today, as opposed to what we've been doing, okay? So I'm not doing rotary brakes. We're doing specific adjustments there. So we don't use, okay, some chiropractors, they'll use a bunch of different modalities, therapies, ultrasound, electric stim, infrared heat, all those things. And again, they're trying to stimulate. Usually it's like manipulative medicine, right? We're trying to stimulate the nervous system, or stimulate blood flow, or stimulate something in that area that's going to mimic normal function. It's not normal function, but we're stimulating it to mimic that. And I did a survey when I was in chiropractic college of all the chiropractors in the area before we came up here, and I asked them, what do you do for therapies, or do you do any therapies? And most of them are, yeah, I do this and this, 2 therapies usually. And why do you do those? Well, because we can bill for it. We can double bill. If a patient comes in and they got good insurance, their insurance will pay for a manipulation and 2 therapies. So that's the majority of the chiropractors out there are doing these, not because I believe 100% in the value of what this therapy is doing. It's because we can double bill. One of the older guys in town said, you got to double dip. He was trying to lecture me and Dr. Sean on how we're supposed to practice and how we're supposed to make money. Well, you got to double dip, guys. When they come into your office, you do your manipulation, then you hook them up to 2 therapies. You got to double dip. So I can't in good conscience say that, I would do any of these things, but in some people's cases, maybe there is a need for it, but the majority of the time, it's kind kind of like the activator. It's like the chiropractor doesn't know anything else to do for this patient, let's throw on a therapy. That chiropractor is afraid to actually adjust this person, let's do an activator, do a clicker. It's not because that's what's best for the patient. Usually it's either because this guy doesn't have the skill to do what is necessary, or I'm going to get paid extra to do it, okay? So, we don't do the clicker. We are the only, no, we're one of two offices. There's three offices in town, because we've got an upper cervical office, yep, that will do before and after actually. But only a specific, a true specific chiropractor will do before and after x-rays, because we're actually looking to make a correction there, change something, either structurally or neurologically, that's going to change something structurally. So if chiropractor that you've been going to or had gone to never did an x-ray, yeah, they're not going to do a post film. But if they took an x-ray initially and then they never did another one, I would ask, why do the first one? You know what I mean? If you're not going to check and see if you actually corrected something. But again, majority of the time it's because that person maybe was in a car accident and they'll be able to bill more to do an x-ray. And then the car accident insurance won't pay for a comparative x-ray to actually see if you corrected whatever it was that you've been writing down that you're correcting. So they don't take an after x-ray, but we take those before and after so that we can compare it and know that we're actually making that structural change there. So the benefits of specific chiropractic care. And B.J. Palmer, again, the son of D.D. Palmer, the guy who developed chiropractic and chiropractic philosophy and multiple techniques, he said if it's not specific, it's not chiropractic. If chiropractic is not specific, it's nothing, okay? Because remember, he's developing chiropractic, the technique, the philosophy, art, and science of chiropractic at the same time as osteopathy's come along. And osteopathy was the opposite. It was never specific. It was always a general manipulation to increase that blood flow and increase that motion, okay? Which, I'm not saying that's a bad thing, that's probably better than like the alternative of taking a drug or something like that for it. But the difference, okay, specific versus non-specific, the benefits of a good specific chiropractor, all the research shows that our immune system functions up to 200% better, okay, and faster response. We get 50% fewer doctor visits. We spend a lot less on healthcare, okay? Drugs, surgery, those things are expensive. Chiropractic really isn't that expensive. Again, the Gonstead system, you're probably looking at, right now it's like 2% of the chiropractic population. They don't learn it in school. They usually have to go find somebody, either at a seminar, there's GonsteadSeminars.com, Gonstead doctors that get together and teach the technique. And then there are, intern programs. Like I'm trying to get my daughter to be able to come here, but she's down at the school where they don't teach any specific techniques, and they're kind of biased against people who do specific techniques. So they're giving me the runaround right now because I do Gonstead, not any other reason, and because I don't do things the way they think that they should be done. But we were just talking about this. We have here probably the busiest clinic in probably Minnesota, and it's a successful clinic, all right? 65% of the kids that graduate in her graduating class won't be in chiropractic a year after they're graduated, okay? They're going to fail in practice. They're going to end up doing something else, selling blinds or rugs or working back at the school, which replicate failure, okay? So I was a little ticked off tonight because I had that conversation with the gal in charge of the intern program. And like I said, it's just because we're doing a specific technique. We're not doing things the way they teach at the school, okay? It's like they're seriously insulted that a student would try to do something other than the way that they are teaching it at that school. So Casey's getting some grief. I'm getting some grief. I'm actually going to have to call him tomorrow and go through the whole rigmarole with him. But one way or another, we'll get her here. That's how Gonstead or any other specific technique gets passed on. Okay? It's like a trade. You got apprentices. You got somebody who comes in and just watches you for a while and learns, you know, they're learning and they're practicing. They're not practicing on actual patients yet. They're just mostly learning and watching. Okay? Then the next step is, okay, we're going to start you off with some easy ones. I'm going to let you adjust this, or I'm going to let you adjust this on this person. I'm going to let you adjust this person, top to bottom, because they can handle it and they're easy enough to adjust right. You don't have to jump on or whatever. So we kind of had to, all of us, go through this, and it literally took probably 3 years to learn the Gonstead system and be decent enough to move everything. Okay, I'm still getting better. It's an art, literally. I still am better than I was last year, you know. And next year I'll be better than I was this year because we're constantly being specific. And when you're specific and you look at that after X-ray and you said, you know what, I didn't get this angle out of that subluxation. Here's what I need to do different. It makes you better. It makes you more specific. So that's the Gonstead system. And I hope you enjoyed that. And thanks again for coming tonight, guys. Sorry if I was a little, but dealing with the schools. I appreciate you guys showing up tonight. And again, you guys who tuned in, just to listen to me yap for a half an hour, we do free exam and x-rays, 2 free adjustments for you to try out the Gonstead system just for listening to me yap. Thanks.